What I want to talk about, so I'm a guy who does a lot with mood disorders. I run the TMS program at Shepherd Pratt, and a good deal of my research work is in mood disorders, and I also wind up being incredibly dyspeptic about how we deal with mood disorders. So what I decided to do for you guys is, instead of doing a talk on depression, then a talk on bipolar, is what I've decided to do is change it so that I'll talk a little bit about diagnosis, or a lot about diagnosis, and you can hear me stamp my feet up here as I tell you why we get it wrong so much. And then we'll go into a talk about the treatment of mood disorders. And I think what I will do is go through both of the slide kits and see what kind of questions you guys have at the end. These are my disclosures. I will say that I do have my price, but nobody's been willing to pay it. So generally I only work for or do speaking for companies that I think have a worthwhile product that I can be supportive of. So I'm going to start with the problems of psychiatric diagnosis. So figure that we've identified, another thing, I'm one of the companies I'm on the advisory board for is a company called Genomind. That's one of those companies that's doing genetic testing. And we've probably identified about 100 different genes that may contribute to psychiatric illness. And one of the problems is that there is no real good way to differentiate what somebody's psychiatric illness is based on their genes. Because when you start to look at, let's say, bipolar disorder and schizophrenia, and maybe there's 100 different genes for each that we associate with having the illness, is about 50% of those genes are in common. So there is less to separate bipolar disorder from schizophrenia and bipolar disorder from unipolar depression than we would like you to believe based on looking at the DSM. Right? The DSM has these clear pigeonhole diagnoses, and guess what? Those pigeonholes don't really exist. And so one patient may have a handful of single nucleotide polymorphisms. And I've also seen within families, I've seen twins, identical twins, same genetic component, different psychiatric illness. So even with the same genetic cohort, you may wind up seeing a different expression of the genes. And so as we understand the underpinnings of these illnesses, and the other thing to say is we really don't understand the underpinnings of these disorders. Of all the psychiatric conditions, I would argue that the two illnesses that we are beginning to have an understanding of biologically are, number one, Alzheimer's disease. So when I decided to expand my research program, you know, when you got to earn your own money, you go where you can get funding. So I expanded into Alzheimer's disease because I've got new compounds that are actually based on understanding that underlying pathophysiology. And the other was the lecture before me, which is addictive disorders. We're beginning to understand the underlying pathophysiology. With mood disorders, not so much. And so we see a lot of different presentations. And do be careful of trying too much to pigeonhole your patients into one diagnosis or another, because it's a much more fluid situation than you've been led to believe. Well, what do we know? So we do know that these illnesses are chronic, recurrent, and progressive diseases of the nervous system. Sadly, some of the best longitudinal studies of mood disorders were actually done in the late 1800s, early 1900s, and you can see some very, very good longitudinal studies of what the natural course of bipolar disorder is. Now you can't get funding to do these 30 and 40-year studies. Mood disorders are associated with functional and structural changes in the brain and in physical health. The reason that people with bipolar disorder die 9 years sooner than people with other conditions is because of comorbid medical conditions. It's not just because if you're bipolar you don't take as good care of yourself. It really is that there is an epiphenomenon that goes along with having bipolar disorder that predisposes you to things like diabetes. If you've ever been hospitalized for bipolar disorder, you've got 2 to 3 times the likelihood of being diagnosed with diabetes, regardless of what medications you ever take to treat it. So these things are incredibly linked. As well, a friend of mine, Yvette Chalene, years ago did a study in which he could predict how long somebody had been depressed based on the changes in the amygdala. The longer you had been depressed, the smaller your amygdala got. And she could predict the people who had been depressed for 5 years versus 30 years because of the relative sizes of the amygdala. You also will see associated changes in neuroplasticity, neurogenesis, and neuroresilience. What does that mean? It means the ability of the brain to adapt to new situations. It's not as simple. When I was in medical school, I was told that we didn't make new brain cells. We were wrong. Actually, we are able to make new brain cells, and one of the traits of people who are resilient is the ability to make new brain cells and the ability to learn new information, which is all about neuroplasticity, neurogenesis, and neuroresilience. Another thing that's very important is that residual symptoms greatly increase the risk of future episodes. So if you look at somebody, and I'll come back to this point a whole bunch of times, which is if you compare somebody who goes into remission after treatment, most of those folks, 75% of those folks, are still well a year later. If you treat somebody who responds but doesn't remit, meaning that they've still got mild to moderate symptoms of the original illness, 3/4 of those people will be sick again within the next year. And that's really important. It's one of the reasons why we try as much as possible to really get people to remission rather than just response. And response classically means that you have lowered your depression rating scale score, depending on what depression rating scale you use. Some use a Madras, Montgomery-Asberg depression rating scale. Hamilton is another common one. And response just means lowering that score by 50%. And the patient may not be well, so if I see somebody at the beginning of a study that is quite ill and has a Madras score of 40, and I get them better to response, and they have a Madras score of 20, they would still be eligible to start a lot of my studies, despite the fact that they meet response criteria. But those are the folks that are more likely to have a recurrence of illness. So what are the current concerns? We do a crummy job in recognizing bipolar disorder. And we do a crummy job because A, we've given you guys poor advice, and B, we have made strict criteria that a lot of folks that I believe have bipolar disorder don't meet these strict criteria, so they don't get treated for it, and they have lousy courses of treatment. We have an under-recognition of psychotic symptoms, particularly in major depression. And the psychotic symptoms I'm talking about is those people who say that they either deserve to die or their families would be better off if they died. And we look at some of these symptoms as being, yeah, that's, if I felt that badly, I would feel that my family would be better off if I was dead. This generally is actually a psychotic symptom. And the problem is people with psychotic symptoms will not get better with antidepressants alone. They generally need to be on an antipsychotic or have ECT. Those are the only treatments that work for psychosis. So as a result, if we pass on some of these psychotic symptoms, and so often, so I'm the psychopharmacologist of last resort at Shepherd Pratt. We are a very large teaching hospital. We've got 330 beds. And as the psychopharmacologist of last resort, I basically get brought in anytime they can't figure out what else to do. So if you ever get hospitalized at Shepherd Pratt and I walk in the room, it's generally a bad sign. I'll still get you better, but it's a bad sign if you need me. And so often, one of the things that I see is that you can see in the admission note that somebody has written that the patient's not psychotic, but they feel their family would be better off if they were dead. Or you'll see other little things that Another place that I work is something called the Retreat at Shepherd Pratt, which is our self-pay unit. So this is a unit, we don't take insurance, we only take cash, and we take suitcases full of cash to come into our unit. So these are folks who can afford all kinds of stuff, and it's amazing how many times people will say, I can't afford to come in, and these are people who are worth hundreds of millions of dollars, and they won't spend the tens of thousands of dollars to get evaluated by us. There's also there's a reliance of clinical presentation in the absence of biologic understanding, and this is one of my chief get up on the soapbox and stamp my feet kind of things, is we wind up lashing ourselves to the mast of the DSM, but the DSM is not at all biologically based. Nothing in the DSM is based on a biological understanding of these illnesses. So as a result, we're looking completely at phenomenology, we're looking completely at what the presentation is, and not really understanding the underlying biology. And as you get a feel for the underlying biology, your vision of the illness changes. Because, like I said, there is less to differentiate bipolar disorder from unipolar depression than the DSM would have you believe. And a lot of these people are in the continuum between these diagnoses, and guess what? My general rule of thumb is, you've heard the advice, if you think you should turn your headlights on, just turn them on. If you think this is bipolar disorder, treat it like it's bipolar disorder. If you think there's psychosis, treat it like it's psychosis, because there's a gray zone. It's not like you're either psychotic or non-psychotic or bipolar or not bipolar. It's a continuum, and there's a huge gray zone between these diagnoses, and you're better off rounding up rather than rounding down, rounding up to the more severe illness rather than rounding down to the less severe illness, despite the fact there are so many people I see that want to negotiate with me about what their diagnosis is. Because everybody would rather have depression than bipolar disorder. Because bipolar disorder is a terrible diagnosis, and no. A terrible diagnosis is one that's wrong. So if you've only been treated for depression, and I'm not a big Dr. Phil fan, but one of his lines is, so you've been treated for depression for 15 years, and yet you're here seeing me because nothing's worked in 15 years, and you want to argue with me about your diagnosis. How's the depression treatment been working out for you? Like I said, there's a poor understanding of conditions that are not represented at all in the DSM. So there's a condition that I consider to be highly recurrent major depression, and these are the folks who have 3 or more depressive episodes a year. Never are manic, but they've got 3 or more depressive episodes a year that are distinct episodes. My impression, and again, I may be in a minority, but I gotta say, a lot of my biologic friends agree with me, we're all biologic, I mean biologic researchers. Is that when you see a highly recurrent depression, it's more likely to respond to mood stabilizing agents than antidepressants. Bipolar spectrum disorders. Again, back to that whole gray zone, diagnosing bipolar disorder is not like diagnosing pregnancy. Pregnancy is bimodal. You either is or you ain't, and don't give me garbage about, well, what about ectopics? Generally speaking, it's diagnosing bipolar disorder is not you either is or you ain't. A lot of folks who I consult on, I say, it's not bipolar disorder, but it's not bipolar disorder. And a lot of these folks, I say, I don't care what you treat it. This is what I'm giving you to treat it. You can call it whatever you want. Current problems in treatment. We have a huge lack of an evidence base for treatment-resistant depression. And I'll try to give you some hints as to how I look at treatment-resistant depression. Again, that's where most of my research work is in. There's confusion over the use of antidepressants in bipolar disorder and bipolar depression in particular. The really brief message there is we really probably, for most people, should not be using antidepressants in bipolar depression. If you heard me speak 15 years ago, I would have said the opposite. I was wrong. I'm different now. Don't based on whether you're going to elect me or not based on what I said 15 years ago. Actually, I don't care if I get your votes or not. I'd rather speak the truth. That's why I'm not a politician. Where did TMS and VNS belong in the treatment paradigm? I'll discuss that a little bit. Again, I'm one of the people who got TMS first cleared by the FDA and have run the TMS program at Sheppard Pratt since 2009. And I'm also about to come out with a study looking at 5-year data on VNS, vagus nerve stimulation, which is an implantable device for treatment-resistant depression. The other big question is what represents valuable versus profitable additions to the armamentarium of drugs. As most of you guys are probably in the internal medicine, primary care world, you guys have everybody in the world outside your door wanting to get in to sell you stuff. I'll at least try to give you a little bit of my opinion as to, what is worth prescribing and what seems. The majority of drugs really are patent extenders, and do bear in mind, despite the fact that the vast majority of what I do is I do pharmacologic trials funded by drug companies. And despite that, I think I tend to try to just do trials of something that's really a novel agent, not the extended release form of some damn thing. But it can be hard for you guys to figure out what's really worthwhile and what's not. Mood disorders. They still go undiagnosed about half the time. So when you look at population analysis, half the people who have a mood disorder have not been diagnosed. Despite the fact that if we actually spoke to them, they would have an illness, but a lot of times they don't want to talk about it because, I'm fine. I don't need those psychiatric type drugs. And you guys wind up having to do an awful lot of psychiatry because a lot of your folks don't want to see a psychiatrist, or you may be in communities in which there aren't psychiatrists who are available. Even when it is diagnosed, it's often incorrect. It is often inadequate because we often overestimate the adequacy of prior treatments. And it's often incomplete, which is that it may not be focused on the chief problem. I've seen lots of people in my office who I take their history, and it turns out that they really have a terrible substance abuse problem, and they say, "Gee, doc, I'll stop drinking as soon as you make my depression better." To which I say, if you got the car at the bottom of a lake, you don't send the scuba diving team down to fix the car. You gotta get the car out of the lake. So I basically will refuse to treat somebody who is actively substance abusing because I'm not gonna get anywhere. It's trying to fix the car that's at the bottom of a lake. As well, high incidence of eating disorders. Often mood disorders come out as eating disorders, and there's a lot of very skinny girls with anorexia who may have anorexia because the one thing that helps their mood disorder is fasting, which causes an endorphin release. So there's a tremendous overlap. And some of the sickest folks I've seen at Sheppard Pratt is when I get asked to see somebody on our eating disorder unit. PTSD. So when our parents were in medical school, the great imitator was tertiary syphilis. When I went through medical school, the great imitator was probably like sarcoidosis, which could present as anything, or one of the other autoimmune diseases. For us in psychiatry, the thing that can present as anything is PTSD. Post-traumatic stress disorder can present as just about anything. It can present as an attentional problem, as a mood problem, as a hypervigilance problem, as a micropsychotic episode problem, all kinds of things. And it can be difficult to tease apart. As well, psychosis, as I mentioned, is often overlooked. So what goes into a psychiatric diagnosis? Certainly presentation, but I worry that we way overvalue presentation because we miss lots of symptoms. If we're just looking at the patient in the office here and now, and this is the main reason that PCPs miss bipolar diagnoses, because most of the time that bipolars show up in our office, they're depressed. And if you don't take a history as to how they were last year, you may not hear about mixed or manic episodes. And you've got to assess functioning in all domains. Don't just take that somebody is not sleeping as that they have insomnia. Are you tired the next day? One of the most clear, almost pathognomonic things for bipolar disorder is these people need less sleep and are not tired the next day. Very, very valuable to ask about that. Eating, concentration, mood, and also please consider changes over time. Because how long have you been depressed? Do you ever feel too good? Do you ever feel like you're on top of the world? There's a very good screening questionnaire called the Mood Disorder Questionnaire that Bob Hirschfeld made up, MDQ if you look it up. And it basically just offers a series of questions, have you ever questions, that is really awfully good at discerning whether somebody has bipolar disorder. Collateral information. Often these folks come in by themselves and there isn't a significant other to give you the full history. People who have bipolar disorder rarely will give you enough information to diagnose bipolar disorder. You usually have to find another informant to get collateral information. As well, you know, having done lots of even studies on treatment-resistant patients, before one of my patients wanted to have a vagus nerve stimulator explanted because she was no better. And I said, would you bring in your husband to our next visit? And he felt very clearly that while her mood wasn't terrific, it was better, and they fought less, which was not an observation she had made about the fact that she was far less irritable with a vagus nerve stimulator in and on. And as well, so you may be able to get more of a history of manic episodes. Rarely do people come into my office and say, well, you know, I impulsively went to Vegas and lost $10,000. I can sure get that history from a spouse. So like I said, especially bipolar and psychotic symptoms. And we often too undervalue this, and one of the problems that you poor guys have is, you know, you don't have enough time with patients to actually ask all the questions you need to ask. Generally, when I'm doing an initial evaluation, I want an hour, and I use every bit of it. Psychiatric history, be careful when an illness is still evolving. As my buddy Dr. Zimnitsky will tell you, he's a child psychiatrist, is depending on where you catch the kid, you may see an illness that's just evolving, that may evolve into something very, very different than what looks to be on first glance. And this is particularly true in young folks, and it's particularly true with young folks with recurrent depression. Is a lot of those folks, particularly if it's an onset before age 16, are going to go on to actually having bipolar disorder. And you can actually cause that to happen by putting them on antidepressants and watching them have their first manic episode. And also be careful based on what the family history is. And also, do not get me wrong, I'm not saying I've never been wrong. I had this one person who came into my office, and he clearly had a depression, no family history of bipolar disorder, put him on fluoxetine, and he calls me up 3 days later to tell me he feels terrific and I am the greatest doctor ever. And he was wrong on a couple of counts. He'd actually been flipped into a manic episode, his first manic episode, by the antidepressant, got him in and got things straightened out. But it can happen to any of us. But what I'm looking to do is to make sure that it's an error within the field, not an error within our own homework, which is, to me, a very different thing. Family history. These psychiatric illness is inherited, as my fellow parents in the audience will say, you understand, we get it from our children. It's often more critical that we give credit to and highlight that as well when you look at family pedigrees, you can see a higher incidence of bipolar kids to schizophrenic parents or the opposite, which is that bipolar parents may have schizophrenic kids. And it's because there is not a lot to really separate these illnesses. They may have different expressions. Medical history and relevant lab work. You guys know more about the relevant lab work. I'm not going to teach you a whole lot about that. I will comment, does neuroimaging help? My take at this point on neuroimaging is that it's still more of a research tool than a particularly good diagnostic tool. And it's similar to my take about genetic testing. So you'll see, and I'm sure you'll get lots and lots of folks coming by your office so that you can do genetic testing at like whatever, $600 or $2,000 a pop. The part of genetic testing that is clearly helpful is when you look, it will tell you some of the parameters for drug metabolization. So it'll tell you about the cytochrome activity and whether people are fast or slow metabolizers, which is tremendously helpful. No argument from me. If you've got somebody who has weird responses to medications, that they have terrible side effects at low doses or no side effects at high doses, get the genetic testing. Absolutely worth it for that population. For a lot of other folks, I gotta say I am ambivalent because a lot of the things like whether you've got a short serotonin transporter, which will predict a lower likelihood of response to SSRIs, guess what? I'm somebody who just sees people way down the river who have failed everything, and guess what? Most of them have short serotonin transporters. And so, because the argument that the company that I consult for makes, and it's not a bad argument, it's basically he argues that I don't need it as much as other docs because I'm already thinking about all the diagnostic possibilities, and this opens the door up for other folks to think about it. But my advice to you is be skeptical. Feel free to go ahead and try it. See if it does wind up being of help to you. Like I said, I'm convinced that the cytochrome profile is a help. I'm not sure we know yet how to interpret, and this is, welcome to medicine. I was a medical student doing my neurology rotation at Mass General when Mass General got its first MRI scanner. And the funny thing about doing MRIs is stuff would show up that the reports from the radiologist would say UBO. Everybody know what UBO stands for? Unidentified bright object. There would be all kinds of stuff showing up on these MRIs that we couldn't interpret. And it sort of reminded me of a friend of mine is an archaeologist, and her joke was when they would be digging up a civilization and you'd find something that you couldn't recognize what it was or where it belonged in society, it was a religious artifact. I worry that that's what happens with us too, is that our ability to find things far outstrips our ability to identify what it means. Which is not to say I don't mean to be nihilistic about it, I just mean to say that we need more research, and I think that the companies are trying to sell something and aren't as interested in supporting research because that's way expensive and may not in fact help their cause of selling test kits. I hope I've sufficiently bit the hand that feeds me. Mental status exam. To me, a mental status exam is rolling throughout the interview. I'm making assessments as to how people's thinking is. Psychological and environmental formulation. Is this where PTSD fits in? Get some idea of a family history, and be suspicious when you start hearing a very traumatic family history and they sort of become very wooden and you're having more reactions to their story than they do. That's PTSD. Bipolar diagnosis. So 7 out of 10 people with bipolar disorder are initially misdiagnosed in specialty mental health center. So psychiatrists correctly diagnose 48% of the time. I will tell you that's even lower than that, but partly it's because my criteria for bipolar disorder is broader than the conventional criteria. PCPs correctly diagnose it less than a quarter of the time. More than a third of folks sought help for more than 10 years before an accurate diagnosis, and 30% of the patients with a diagnosis of depression or anxiety actually have bipolar disorder. So I'll try to give you a little bit of some hints as to when to be more suspicious that your person has bipolar disorder, but if it makes you feel any better, like I said, I am the main psychopharmacologist for the retreat at Shepherd Pratt, which is our premier unit. We charge people, I think it's something like $45,000 for a 20-day length of stay. You get me, which is worth probably half of that, sure. But what's interesting is these are people who can afford whatever in terms of their psychiatric care. And so these are people who generally have had very, very high-priced care coming before us. And still about half the time I change people's diagnoses. And people still come back, so I guess somebody thinks we do okay. So what kind of things am I looking at? So in the column manic mood and behavior, all that stuff you should be already pretty used to, and that's the easy stuff. The psychotic symptoms, again, can hide, particularly delusions. It can be kind of unclear, and you can hear about delusions of poverty or grandiose delusions. The other problem is that, having grown up in the Harvard system and spending a year at the Harvard University Health Service, sometimes people's grandiose delusions are in fact not delusions. These are, you'd occasionally see these very talented people. Like I saw this person who was taking 4 different foreign languages the same semester. 4 different foreign languages, including Russian and Chinese. And I said, how are you doing in these courses? She said, I'm getting all A's, but I feel kind of stressed. God bless her. But also be careful about the dysphoric or negative mood. The other thing that I think a lot of people pass off is mixed states. And I'll discuss a little bit more about mixed states. And this is depression with activation. And so often it winds up being diagnosed as depression with anxiety. Bear in mind, agitation to me, which represents a sort of physical manifestation. Anxiety tends to just be worrying. If it has gone beyond worrying and somebody has racing thoughts and physically can't sit still, that's a mixed state. That's not depression with anxiety. A lot of irritability, again, that's not depression with anxiety. Hostility as well. Racing thoughts, it can be very hard to differentiate between obsessional thoughts and racing thoughts. Disorganization and inattentiveness. Again, it can be hard to diagnose because the other problem is you can see lots of people with bipolar disorder who also have ADHD. But do bear in mind that bipolar disorder is a cyclical illness. ADHD is a constant. So you need to make distinctions. If there are times that they're much better organized and much worse organized, more likely to be a cyclical mood disorder than it is to be just ADHD. The Bipolar Diagnostic Star. So these are things that you hear about that you should raise your suspicion. So early age of onset. So if you see people before the age of 25 who have had a high periodicity of mood swings, be suspicious. A loaded family history. If everybody in the family has bipolar disorder and the kid sitting in your chair just as depressed, they got a bunch of loading for bipolar disorder. I would be very careful. Course of symptoms. Anybody, at any time compares their mood change to a light switch, that is bipolar disorder. People with depression sort of fall into depression and come out of depression. If somebody says, I woke up and I was depressed, that is bipolar disorder until proven otherwise. So either down or up, any change like that happens quickly, that is bipolar disorder. And that's what bipolar disorder looks like. You'll see these quick mood switches. Response to treatment. something that I like to call therapeutic misadventures. Other people may call malpractice, is if you see treatment emergent mania or agitation, be suspicious. And you know, a lot of the times I'll see somebody who has just been treated for depression, and I take their history of their response to treatment. They say, well, you know, I went on that fluoxetine and I just got so agitated, I couldn't sit still, I couldn't calm down, I couldn't sleep. That's likely to be bipolar disorder, even if you know very little else. And be suspicious of people who become really agitated with antidepressants. I'm less suspicious of multiple antidepressant failures because I see a lot of treatment-resistant depressives. Erratic or uneven antidepressant responses. You will see poop out, which is a phenomena that somebody who's responding perfectly well for months and then just stops responding. I don't know that that graphs real well, but when you hear about lots of erratic responses to the same class of medication, please be suspicious. And obviously, if somebody is hypomanic or manic, that becomes kind of easy, hopefully. Risk of misdiagnosis. The biggest confusion is around bipolar depression versus unipolar depression and agitated depression versus a mixed bipolar state. I think it is better to err on the side of overdiagnosis of bipolar disorder due to the risk of therapeutic misadventures. You know, as one of the axioms primum non nocere, firstly do no harm, you're better off erring on the side of doing something that is less likely to make somebody worse. So some diagnostic considerations. I mentioned the difference between depression, anxiety, and agitation. It really has to do with how it feels to sit with them. If somebody starts, you know, and one of my jokes about how I make psychiatric diagnosis is it depends on which of the hairs of the back of my neck stand up when I'm meeting with them. And if I start feeling more anxious, it may be anxiety. If I start feeling more agitated, it's more likely to be agitation. And so, you know, I listen to what these folks are saying, and I pay attention to how they're making me respond. And when I get incredibly worried, it usually means that they're really sick, usually suicidal or severely depressed. Depression plus a family history of bipolar disorder, be really suspicious. Substance abuse, you heard the lecturer talking about substance abuse. Generally speaking, if you see somebody in your office with depression, but their substance of choice is a stimulant, most of those folks will have bipolar disorder. People with just depression do not like to abuse stimulants. Why don't they like to abuse stimulants? Everybody loves stimulants. They don't like to abuse them because what happens, particularly with these real short half-life compounds, after it wears off, they get horrifically depressed. And most of my depressed patients say, I'm not doing that again. For the bipolar patients, that's just another ride on the merry-go-round. And the other thing for a lot of the bipolar patients is they will have much more persistent highs. They can get launched by some crack or some cocaine. The other thing I'll say is, if I was an evil scientist, and hopefully I'm not, if I was an evil scientist and I want to invent the most addictive substance possible, it would look a lot like crack. How long does it take crack if you smoke it to get into your system? 10 to 15 seconds. It lasts for 10, 20 minutes, and it leaves you craving more? Come on.
Great business model.
It's a great business model. Amazing that Trump didn't get into that. That's why the first taste is free. But generally speaking, like I said, depressed people don't go for that. The people who like meth, who like coke, who like crack, or any other stimulant are generally going to be bipolars. My buddy Mike Face talks about the rule of three. And I apologize if any of you guys qualify on this count. If you've been married 3 or more times, more likely to be bipolar than unipolar. If you've had 3 or more jobs in the last 5 years, more likely to be bipolar. You know, it's sort of like the Jeff Foxworthy routine, you know, you might be a redneck, you might be bipolar. If you see somebody with two clearly different depressive presentations, a retarded depression and an agitated depression, that's bipolar disorder. That's somebody cycling between a major depressive episode and a mixed manic episode. History of family drama or violence. Again, when bipolar parents have bipolar kids, very, very noisy house, very violent house often. Rapid response to antidepressants or agitation in response to antidepressants. Rapid on-off criminal history. The only studies I've ever done that I had to drop somebody out of the study because they were in jail for getting in a fight with a cop. That's my bipolar studies. Multiple affairs or judgment errors, more likely to be bipolar disorder. Although there's a number of people that you can see that are treating their depression with affairs because you can get that wonderful endorphin release from novelty. Not here to judge. Substance abuse is the biggest predictor of a poor outcome. So my buddy Maurizio Towen did a long-term study looking at bipolar disorder. The thing that best predicted a bad outcome was alcoholism, even better predictor than whether or not you stayed on your lithium. Long-term rates, the lifetime incidence of substance abuse in bipolar patients is 60%. The point prevalence, depending on what study you look at, is between 30 and 40%. I think it's closer to 40% of folks with bipolar disorder at any point in time are abusing substances. The general number for the whole population is about 10%, maybe 11%. So these folks are 6 times as likely to abuse substances. The substance abusers are more likely to be rapid cyclers, be lithium non-responsive, have higher suicide rates, more functional disability, and have more depressive features. Other than that, it works out great. They're likely to be excluded from clinical trials, so the data set we have on these folks is quite limited. Anxiety disorders, no controlled studies of anxiety and bipolar disorder. There is a higher rate of treatment non-response, substance abuse, and suicide. The single worst predictor for suicide of any psychiatric symptom is panic attacks. And so be wary of your folks with panic attacks because they just feel horrific and they will often do stupid things when they're in the midst of a panic attack. Comorbid frequency in bipolar disorder may be 50%. ADHD, really common diagnostic concern in the pediatric population. The problem is all bipolar patients will meet most of the criteria for ADHD, but fewer of the ADHD patients will meet the bipolar criteria. You want to differentiate between the cyclical and the constant courses of the illness, and be careful in using stimulants. One of my jokes that I have a feeling Brian has heard me make before is if you're not sure whether it's bipolar disorder or ADHD, give the kid a stimulant. If they get worse, it's bipolar disorder. If it gets better, it's bipolar. Please don't do that. That's really a joke. Okay, it's not a very funny joke. So for depression, you want to have several of these symptoms. You want to have 5 out of 9 symptoms, and that's one of the reasons I love the DSM. Is it's the Chinese menu diagnosis. So many from column A, so many from column B. You have to be a certain age because Chinese restaurants don't do that anymore. But it used to be you'd get to pick from column A and column B. Anyway, these are the column A things, and you need to have 5 of these 9 symptoms. Most weeks I have a good 4 of them. So I'll tell you about my problems later. There's many different presentations possible. And this is one of the things that's so important is if I had a room full of people with either depression or bipolar disorder, everybody may have a different presentation. Some people sleep too much, some people sleep too little, some people eat too much, some people eat too little. These are, it's very, very different. And it's better to think of it as depressive disorders and bipolar disorders as opposed to a single disorder. And the myriad of different presentations may suggest different interventions. I'll discuss that a little bit in the next talk. And be careful to rule out other causes, other illnesses, and other comorbidities. I'm not going to spend a lot of time on this because we've already discussed how you evaluate these folks. Be careful about general medical disorders. People aware what generally the first symptom in the presentation of dementia is? is depression. And so be real careful. The other good news I have for you is we may be coming out with some things that may work early in the course of dementia. So it may be actually more important for us to recognize it up front. Autoimmune diseases. And a lot of my friends are doing a lot of research into the overlap between autoimmune diseases, because these are autoimmune diseases and mood disorders both have high levels of circulating inflammatory cytokines, like tumor necrosis factor alpha and the interleukins. My expression about what I do is, don't always know what I'm doing, never bored. Diagnosing treatment-resistant depression. Treatment-resistant depression is the failure to respond to two or more agents to carefully treat a diagnosed condition, but it doesn't count if your diagnosis is wrong. It doesn't count if you've had inadequate treatment by dose or duration. If you really want to do this, and this is really the graduate level psychopharmacology course, and most of you, other than Mary Lou and Brian, are not psychiatrists. But the point is psychiatrists have crummy records. You guys often have crummy records as to what you've done. Best thing to do is to get pharmacy records. You will find out whether somebody took an agent and for how long. And the simple rule of thumb is if somebody refilled a prescription once, you know that they took it for a month, because you don't refill a prescription you don't take. Even if it's only $3 at Walmart, you still don't refill it if you're not taking it. Non-compliance, obviously, if you refill a prescription, that suggests that you're complying. Substance abuse makes all psychiatric illness non-responsive, and PTSD is often missed and diagnosed as a mood or a psychotic disorder. As I said, more than 3 episodes a year may represent a cyclical mood disorder. Anger episodes that seem explosive, I'm always suspicious of. I had one person that their bipolar symptom is every 3 weeks they would rip apart their office. So Staples was really happy to do business with him because he would break all of his file cabinets. Differentiate between insomnia and decreased need for sleep. Periods of very high energy or productivity. I will confess that I get most of my work done in 30% of the time I've allotted for it, because it takes me that long to get myself moving, but I'm very productive. Pressure of speech, you have to watch out for those of us from New York City, because we all have pressure of speech, so just check where we're from before you assume that it's bipolar. Intense irritability, getting into verbal or physical fights, and that's one of my simple screening questions. Do you get into verbal or physical fights with people outside your family? And that's one of my criteria for irritability. When to consider PTSD. Often there's no report of childhood abuse and can represent as a disconnect between content and affect. Again, when somebody's story makes you cry and not the patient, be suspicious. Are there periods of dissociation? Are they losing time? A sense of emotional numbing or hypervigilance. And patients who present with more anxiety or irritability than depression. Often I find have PTSD. Chronicity. The longer an episode persists, the harder it is to treat. These are some statistics that I'm hopeful that I can change, which is that at 6 months, only 50% are recovered. If you're ill for 12 months, only 16% are recovered. And after 5 years, only 1% recover. Once an episode exceeds 12 weeks, the chance of recovery drops 37%. These are some scary numbers. But you know what that means to me is job security. This is sort of what the overview of levels of treatment resistant. This is a paper Mike Face and John Rush wrote a couple of years ago. Actually, more than a couple of years ago. 20 years ago, but who's counting? You get to a certain age. So failure to respond to one trial, 2 different trials plus augmentation. Stage 3 is failure of a second augmenting agent. Stage 4 is failure to respond to ECT. Here's some definitions. Non-response is less than a 25% reduction on a depression rating scale. Partial response, and for TRD you really care about partial response, because partial response can be the difference between being completely disabled and being able to work. Treatment response is a greater than 50% reduction, and remission is no functional symptoms remain. Single episode versus recurrent. Recurrent treatment-resistant depression is easier to treat than the people who've been depressed for 30 years. You want to verify the pharmacy records. And some folks will, in fact, respond to another medication from the same class. And you guys tend to do that more than I do, which is that if one SSRI fails, you may move to a second SSRI. And despite the fact that I'll move to a different class, there really is not enough data to suggest that what you need to do is what I do. I'm just impatient. When I think about TRD, I think, is there anything that's giving me a clue as to where to grasp onto the illness? I sort of view it as almost, where's my handle that I can manipulate something? Has the patient ever responded to anything ever? This includes medications from any class, including opiates. I'm currently working actually on an opiate receptor antagonist that appears to have some efficacy in treatment-resistant depression. Stimulants or benzodiazepines, neurostimulation, ECT, TMS, and VNS. Does exercise help? There's a lot of folks I see for the first time who are obligate runners who only get depressed once they stop being able to run. And so the first time I see them, it tends to be these skinny women in their 40s who have an orthopedic injury, can't run, and now they have these terrible depressions that they've been treating with their exercise. Has the patient ever had an eating disorders? I mentioned anorexia can give a sense of well-being because of the endorphin release. Any self-harm? A lot of people who cut themselves do it for either an endorphin release or to distract themselves from the pain that they're suffering. Final words in this kit: be thoughtful when evaluating these folks. Don't be as concerned with fitting patients into a limited diagnostic box. Look to establish a sense of shared target symptoms. So when I meet with the patients on the retreat, let's agree on what our target symptoms are. Let's forget about what the diagnosis is, but let's agree on the target symptoms. There are no clear diagnostic lines between categories. Real important message. In general, you're better off erring on the side of treating possible bipolar or psychotic symptoms as opposed to dismissing them.